Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. The show will help you as you develop your own aging and care plan.
I am Joe Steckler. Welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic for today is stenosis and sciatica. With me in the studio is Dr. Deukmedjian, who is board-certified neurospine surgeon for the Deuk Spine Institute. Today, I think that all of you seniors, just like me, are going to get a lot more information on sciatica and stenosis. And if you're like me, I know it hurts, and I know a lot of you out there hurt, and Dr. Deukmedjian is going to talk about it, and he's going to tell you about how we can help ourselves. Dr. Era.
Hi there.
Glad to have you here.
Good to be here, Jeff. Thank
That's
you.
great. And then you asked me when you came in today if I wanted you to wear your scrubs or you got a white coat as office set, and I said, I like the scrubs.
Well, this is what I wear to work. Well,
that royal blue sort of sets you off. You have brown eyes, though, right?
Yes, sir.
You know, if you hurt, if you lose your ability to enjoy life, to realize that there's a time and a place to laugh, I think you've lost everything. I think it's important that a person keep their sense of humor, even if you hurt. And I'm sure that it hurts you as a doctor to see patients who suffer.
It does. It's interesting you say that because before I came here to the studio to meet with you and to help educate our guests, I was at the hospital. And I was seeing 3 patients that I did surgery on yesterday for. All 3 of them had spinal stenosis. And as a result of the spinal stenosis, they had pinched nerves and they had pain either going into the arm or their legs. One of the patients had a back surgery and the other 2 had neck surgery. All 3 of them this morning, the day after their surgery, are going home, and all 3 of them have no more pain in their arms or legs. So that pain, as you know, in the legs, we call it sciatica, when it shoots from the back all the way down the leg, and that's usually from a pinched nerve. So when I was a kid, and I was telling one of the patients this morning at the bedside, I said, as a kid, you know, young kid, 5, 6 years old, I remember seeing people walking around in the shopping center or wherever it was, and they looked like they were in pain, they were suffering. And that always bothered me. At the time, I didn't know what I could do. I just felt very bad for them. And in my mind, I knew somehow I wanted to help those people someday. And so I ended up becoming a neurosurgeon. And when I was talking to my mentor, who's a very famous neurosurgeon, Dr. Marty Weiss at USC, everybody knows him and respects him. And he said to me, what area of neurosurgery particularly interests you? Is it the brain? Is it the nerves? Is it pediatric neurosurgery? And I said, actually, it's treating pain. And he looked at me funny and he said, nobody goes into pain. And I said, well, maybe I'll be the first one to do it. So here I am, and I've built my practice and career on helping people in pain.
How long have you been doing this?
Well, I guess that's an interesting question. I don't know when it really started. But I became a neurosurgeon. I finished my training, my residency and fellowship in 2004, and I've been in Brevard County for the last 8 years.
Okay, and where did you do your residency?
I trained at the University of Florida in Gainesville. It's one of the top programs in neurosurgery.
A number of the people I've had on our new series of shows for Focus on Seniors have gotten their education and their training in many different fields from the University of Florida.
Excellent school.
But you went to a good school to get your undergraduate work, right?
I went to UC San Diego in California and USC for medical school in Los Angeles.
Didn't you go to Notre Dame too?
No, I didn't go to Notre Dame.
I thought you did.
No, not in this lifetime. I'm a Trojan.
Yeah, okay. So you were one of those guys that wants to beat Notre Dame out there.
That's right. That's right.
Okay. It's making you laugh too.
It is.
See? What is spinal spinal stenosis?
Yeah, spinal stenosis obviously involves the spine. That's why it's called spinal stenosis. Stenosis is a term in medicine that's used in different parts of the body, and it means to be narrowed. And so spinal stenosis is specifically talking about narrowing in areas of the spine. And there's really three zones of the spine that can become narrowed. There's the central part of the spine that runs from the bottom of the skull all the way down to the tailbone. And then there's kind of the lateral recess, which is off to the side on the left and right. And then there's the neuroforamen. The neuroforamen are the actual holes in the sides of the spine where the nerves come out. And when those nerves come out of the neuroforamen, they go down into your arm or they go down into your legs. So spinal stenosis can be narrowing of any of those three zones in the spine, either in the neck, the thoracic, or the lower back. And spinal stenosis typically causes, in the neck, a pinching of the spinal cord, which can cause damage to the spinal cord. Patients may have trouble with their coordination in their hands. Some patients will have numbness and tingling in their fingers. Some patients will lose their balance and have difficulty with their gait. They may end up in a wheelchair because of spinal stenosis in the neck, pinching the spinal cord. More frequently, though, than the spinal cord being pinched, nerves get pinched. And the nerves are really kind of like if you think about a wet spaghetti noodle. That's how delicate those nerves are, and that's about how big they are. And they come out of the holes in the neck and the holes in the lower back.
The nerves are as big as a spaghetti noodle?
That's correct. Like a wet spaghetti noodle, they're very soft and it can be damaged easily and pinched in half easily. Nerves are very delicate. They can be pinched very easily. So when you have narrowing of those holes where the nerves come out of the spine, you get a pinching of those nerves in that area, and the nerves can become damaged and cause symptoms in the arms or legs.
Okay. How can you tell before you operate, or can you tell before you operate, where the pinching is? Can you tell that?
You can, through an MRI scan or a CAT scan or x-rays.
CAT scans can show that?
Yes, sir. CAT scans can show it. As a matter of fact, the MRI is probably the best imaging test that shows us structurally where the nerves are being pinched. However, it's very important to understand that we should not base decisions about surgery solely on an MRI scan or any imaging modality. Really, what we have to do to be responsible clinicians and have good outcomes, we have to listen to the patient's history. And the history really has to match what we're seeing elsewhere. The physical exam is the second most important thing. Are we finding that certain nerves that we see are being pinched on the MRI? Are they indeed being pinched on the physical exam? Is there numbness in a certain area that that nerve goes to? Is there weakness in certain muscles in the legs or arms that that nerve goes to? So the physician, to do really the right job for the patient and really figure out which nerves are being pinched, has to look at the history, the physical exam, and the imaging studies. And there's an imaging study we really haven't talked about yet, and that's called an EMG nerve conduction study. An EMG is an electromyogram, and what we're doing here is the nerves, as they come out, they go down into the arm or the leg, they go to muscles, and they go to skin. And so if a nerve is being pinched or damaged somewhere, anywhere from the spine all the way out to the periphery and the skin, different diseases affect the nerves in different places. And so we can put needles into the muscle and check the muscle's response to placing that needle, or we can put electrodes on the skin and we can run current through the nerves and see if they're working correctly. So by doing these tests with a nerve test, we can actually help determine what kind of problem patients are having.
And before you operate on a person for stenosis, do you do all those?
Oh yes, we do that on every patient.
Okay, now you've done all this and you're pretty well located. Let's say if a nerve is pinched when it comes out of the left side of the back or the right side of the back, the lumbar area.
Yes, sir.
And those are the ones that control the pain that goes down into the legs.
That's correct.
If you think you've got the pinched area located, and then when you open a person up, do you have one of those glasses on that sees real bright things?
So I think you're asking me if I use...
How do you see? Can you see it?
It's hard. Yeah, I mean, you can't really see well with your naked eyes. You need illumination, which is a powerful light source to look down into that surgical incision hole that you've made, to look way down there. And the other thing you need is magnification. So you need illumination and magnification.
And you can see that? Can you see where the damage or the pinch area is when you look?
Absolutely.
You can do that?
Absolutely, every time.
Every time I talk to you, or I talk to these doctors that work on the back, I learn more.
Good.
And I know you like to teach people. And I hope you're listening to what Dr. Era is saying, because those of us that suffer from the type of pain he's talking about need to be better informed of what can be done. So, in my thing, do you feel you pretty well covered the symptoms or not?
No, I think we can talk a little bit more about the symptoms.
Okay.
And just to clarify with everybody, all of our audience, the symptoms are really what the patient tells the doctor. Okay, and so we're looking for certain symptoms. For example, there's pain, which is, some patients say, I don't have pain, I have discomfort, or I have burning. Well, we consider all those to be pain. And so pain can go down the leg. We have numbness, which can occur in the feet or the leg from a pinched nerve. We have weakness, which can occur with any of the muscle groups in the legs. And so most commonly we'll see weakness with cocking the foot up. So a patient who has a bad pinched nerve at L5, for example, may have weakness in the muscle that cocks the foot up when you're walking. And so they'll drag that foot, and we call that a drop foot. And that can actually cause them to fall. And then finally, the last symptom that we can have is a tingling in the toes or feet, like a pins and needles kind of feeling from a pinched nerve. Some patients actually may also get bowel and bladder problems. That's if it's a severe case of stenosis. Okay. They may not feel that their bladder is full, and they may have an accident, start having accidents.
Can stenosis cause pain in one or the other or both knees?
Stenosis usually will not cause pain that's isolated to a knee. No.
I always ask, I ask, honestly, folks, what I do is I talk about myself a lot because Dr. Era answers my questions. And it's for me, it's so much easier to ask a question about something that I'm aware of. Let's say that you've decided that somebody has stenosis. They exhibit all the symptoms, you've examined them. What are the sort of recommended treatments from the easiest to the hardest?
Great question. Well, I mean, you hear the old adage, there's no one treatment for everybody. And really, treatment has to be tailored to the individual patient. But when somebody has symptomatic spinal stenosis, and it's really bothering them and affecting their quality of life enough that they want to see the doctor to get something done about it, there are a few options for them. What we always start with is therapy. We always start with a course of physical therapy or rehabilitative medicine, exercise program essentially, to try to strengthen the core muscles in the back and get them mobile and active and see if that helps the symptoms or does it make it worse. Some patients will actually benefit from that course and they're going to go on and not need any surgery at all. Remember, what we're treating here are symptoms. It's very important. We're not dealing with an infection or a tumor, something ugly like that needs to come out. We're talking about fixing how people feel so that they can improve the quality of their life. They can go out and do activities that perhaps they couldn't have done because their legs were bothering them. So my target, my endpoint for treating a patient is let's get rid of those symptoms that are bothering you, that are keeping you from doing things. And one way to do that, again, is therapy, and that's always something we try in the beginning. Another option is to do something called an epidural steroid injection. Epidural steroid injections should be and are possible to be used to treat leg symptoms or arm symptoms. I don't recommend them for people with just back pain. They really do best if they're targeting a symptom such as leg pain. An epidural steroid injection won't work in everybody. It works maybe in half the patients, and generally the relief from the symptoms is short-lived. So it may last 3 months, 6 months, maybe a year. I've had a couple of patients where the epidural injection lasts longer than that. What is an epidural steroid injection? Well, basically we're taking medicine and putting it right into the spinal canal where the stenosis is. So if you were able to go inside the spine and look at those pinched nerves, what's really happening at those pinched nerves is the pinching is causing inflammation around the nerve root. And that inflammation is what the patient is feeling and perceiving as those symptoms in the leg. So how do you reduce inflammation? We use anti-inflammatories, they're medications. The most powerful anti-inflammatories are steroid medications. So what we do is we take a small amount of steroid and put it in a needle and inject it right around the nerve roots that are being irritated. And that we call that an epidural steroid injection. And there's really 3 ways to do it. And I don't want to get into too much detail, but certain ways are better than other ways, and that's something you have to discuss with your doctor who does the procedure to find out what's best for you. Finally, there's surgery. And surgery is certainly a good option if your stenosis symptoms are bad enough and you don't get better with the conservative management using therapy and perhaps epidural injection. And surgery, there are many different ways to do surgery, many different surgical options, from laminectomies and foraminotomies to endoscopic laser surgery, which is a new technology that I perform,
All right.
to fusion surgery, to interspinous devices. So there's a whole variety of different surgeries that are available for patients. And I will tell you that, again, as I said before, when I started this conversation, no one treatment is best for everyone. So you need to really sit down and figure out how many levels are being affected with the stenosis. Is it one level, two levels? Is it just the right side and the left side? Which side is the patient having their symptoms on? Is there any deformity of the spine? Is there scoliosis? Is there listhesis or slippage of the bones? Because some patients will need a reconstruction while we're in there doing the decompression, taking the pressure off the nerves. They're going to have their spine realigned and then stabilized. So it really depends on the individual patient as to what we do.
When you say a person has to have their spine stabilized and realigned, can you do that and the spine still stay flexible?
Well, right now we're looking at technologies that will allow us to stabilize the spine and maintain flexibility or movement. The answer in short, is yes. There are options that are available that allow flexibility and stability, increase the stability of the spine. But again, it just depends on how unstable the spine was to begin with and how much deformity there is and how good quality the bone is in the patient, because osteoporosis comes into play when you're talking about surgery.
You're talking about losing the pad between the spine joints?
Well, that's osteoarthritis. Now, osteoporosis is kind of a weakening of the bones themselves. And if you're and if you're talking about stabilizing the spine, we're talking about putting in hardware, so some type of a spinal implant. And when you put a spinal implant in, almost every spinal implant I know of that's available requires that the bones be strong enough to accommodate the spinal implant and provide strength above and below it. So if the bones are weak with osteoporosis, then certain spinal implants would not be such a good idea in certain patients.
But all that you can tell before you operate.
That's correct. You should be able to tell before you operate.
Do you find that people that might have stenosis would also have a problem at L3, 4, or 5, where they need to have those joints fused?
Yes. So sometimes spinal fusion is necessary as well to treat stenosis, but usually it's less commonly necessary. And that gets really technical. In my practice and my own research, what I found is that one of the most common causes of what's called failed back syndrome or failed spinal surgery syndrome is what's called persistent lateral recess or foraminal stenosis. In other words, the patient never fully had the stenosis treated with the surgery that they had done. And so my personal philosophy is to aggressively treat the stenosis with the surgery that I do. And sometimes fusion is necessary to do with a decompression.
I've listened to several doctors explain how they fix stenosis. Can you give our viewers a sort of a lay perception of how you root that spine, or what you do to open up that opening so the spine, so that cord goes through there better with more room?
Right, and it depends on whether we're talking about the cervical or the neck area versus the lower back.
Let's talk the lower back area.
Yeah. So for the lower back, there's different approaches to the spine, and the approaches are going through the belly, going through the side, or going through the back. And generally, the most common way to treat spinal stenosis is to go through the back.
Okay.
And so one option is to make a surgical, all of these involve surgical incisions, which is a cut in the skin. And they all have to be done under sterile conditions to minimize risk of infection. But basically, one option is to go in and basically your goal is to open up the hole where the nerve comes out, which is actually kind of on the side of the spine.
Yes.
but all the traditional approaches surgically are to go through the back. So you actually have to drill a hole in the back of the spine first in order to go around and open the hole on the side of the spine to take the pressure off the nerve.
Why do you have to do that?
That's just the way it's been done for years and years. And then again, that's the reason why the new technology with the endoscope, doing it arthroscopically with the laser, is actually better, because we don't have to open a hole in the back in order to get out to the side. Yeah. So the reason we do it that way, all the training to date, all the instruments that have been developed over the years, they're all designed to approach the spine through the back for the most part.
And so when you open the back up, and when you use that drill to open up that hole, you actually are seeing flakes come off the bone to open the hole?
Yes. Yes. Yeah. So there's really two ways to open that hole. One is using what's called a kerosene punch, which is a special metal instrument that's real long, that has a very powerful mouth that bites off pieces of bone. And you do that one after the other until you get a hole big enough that you can work and take the pressure off the nerves. The second way of doing it is which is what I use a combination, is to use a high-speed drill. And that drill, rotates at about 60,000 RPMs, and we have different bits or burrs, and we create holes very quickly and safely.
Like that dentist that does in your jaw?
Yeah, not in my jaw. I brush my teeth regularly.
Well, but I noticed you have big hands. You have big arms.
Yes.
Is that the drill you hold, right?
Yes. You're holding that drill, and you have to hold it very carefully.
Do you just sort of hold your hands up, or do you have a bit of lever on your hands? How do you do that?
Yeah, well, I actually I don't feel like I have to be a macho guy or prove anything, so I actually rest my hands on the patient. I find that that's the most safest and most stable way of holding the drill, and so I usually put one hand on the patient's back or the neck, depending on where I'm at. And I use my right hand, or I could do it with my left because I'm ambidextrous, but I will, use the microscope or something to magnify and illuminate, and I can get down there and I can see exactly what I'm doing. I work on millimeter, half millimeter areas with the drill.
Okay. A question that's very important, I think, is I wrote down here, long-term effects of failure to treat stenosis and sciatica.
All right, so what are the negatives to not getting it fixed, is what you're saying. And
yeah.
Basically, like I made the analogy earlier when we were talking about a wet noodle or spaghetti. They're very soft, they're easy to pinch in your finger and break. So the longer you leave the stenosis or narrowing pinching those nerves in your back, the more permanent damage that's going to occur. In other words, the less likely you're going to get better after the surgery when you finally do get the surgery. That doesn't mean if you have leg pain, suddenly rush to the spine surgeon and get your back fixed. Patients with symptoms should have pretty much consistent symptoms for at least 6 months, maybe a year or longer, before they consider surgery. Now, there are some exceptions to that. If you have lost control of your bowel or bladder suddenly, that's usually an emergency if it's due to spinal stenosis and needs to be fixed right away. If you have a drop foot where you lost strength in your leg and you can't cock your foot up, you want to get to the doctor right away, to the emergency room.
I can still cock my foot up.
Yeah, but you want to get there right away, usually within 8 hours or so, the sooner the better. And so there are some situations where you need to get that stenosis treated emergently. But generally, stenosis is a progressive disease that occurs over months and years, where the symptoms gradually get worse and worse and worse. And by not treating it, you're putting yourself at risk for having permanent weakness, permanent numbness, and permanent pain.
That's how a lot of us go from 6'2" to 6'1" to 6 foot. You're laughing, but that's true, isn't it?
I think that you're right that the discs, which are the washers between the bones, they do shrink over time, and that's how a lot of us lose our height.
But that's a common thing, isn't it?
It's common, but I wouldn't call it normal, and you almost did, and you're right not to call it normal. I see 85-year-old patients with perfectly normal discs in their spine. They look like a 15-year-old's disc. They're big, they're tall, they're normal looking on the MRI. And so I don't believe that degeneration of the discs, which predispose you to spinal stenosis. I don't believe that that's a normal aging process. I think it's more common as we get older due to wear and tear of those joints.
Can you do anything to prevent that?
I think prevention is going to include things like not lifting things that are too heavy, keeping your lifting lighter, not doing any kind of repetitive bending at the waist. So if you have a job that requires you to bend over and pick things up all day, that's not good for your back. You're going to wear those discs out much faster. We know that there is not just behavioral aspects to the discs wearing out, but there's also genetic components.
Right. Yeah.
And so
we didn't even get into that.
We didn't get into it. And there's not much to say except that some people are more predisposed to having disc damage, which then predisposes them to spinal stenosis because of the genes that they inherit through their family tree. And you see these kind of problems run in families. I get patients all the time. They come in and they say, oh, my parents had this problem, and my grandparents and my kids are having back problems and neck problems. So it's very common that there's a genetic predisposition in the structure or physiology of the tissues around the spine that predisposes these people.
We're almost out of time, but what, in the last minute and a half, what would you want our viewers to take away from this about sciatica? We didn't even talk about sciatica. Well, we have talked about it. What would you think that's important for them to learn from what you're talking about?
Well, if I had to list a few things, number one, never go based on just the MRI. Okay? Make sure you get an exam by a very competent physician who's able to look at other causes of leg pain besides just the spine. There are causes of leg pain that do not involve the spine at all, and they're quite frequent. And I do see patients that have come to me over the last few years that have had spinal stenosis surgery by other physicians in the community, and they got no better after the surgery, and they don't know why. So they come to me and they want to know why. And when we do an exam, we find out that their blood vessels in their legs are too narrow, and they're not getting enough circulation in their legs, or that the veins in their legs are too wide, and that the valves are incompetent. They're getting venous hypertension or stasis of venous blood, and that causes similar symptoms to sciatica. Or that there's a muscle in the buttock called the piriformis muscle, which gets all overstretched and then bound up, and that pinches the sciatic nerve and causes sciatica. So all those conditions, and there's others, that can cause sciatic type pain that are not pinched nerve and spinal stenosis. So number one, get the right diagnosis. Go to a competent physician for that.
Go quick.
And I guess I'd leave it at that.
All right. I would like to keep talking, but we're out of time. And thank you, Dr. Error, for being here with us
today.
Thank
you, sir, for having me.
Very much.
I appreciate it. It's always a pleasure.
And thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL 1300 AM at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. And thank you for watching, and I hope you learned something from Dr. Deukmedjian of the Deuk Spine Institute. Thank you for watching.